Welcome everybody this afternoon. For those that don't know me, newer board members or superintendents, I'm Don Watruba, the Executive Director of MASB, and kind of flipping the Members Matter webinar that we've had over the last 8 months a little bit today. Clearly we're talking about an important issue for our members, but unlike in the past where we've had kind of that back and forth and sharing between members, in light of the dual announcements of last week, I wanted to try to get some expertise on today to share with you what's happening and how things are functioning in the antigen testing and the vaccination space. And so with us today, we have two guests. We have Brandy Johnson, who is the Education and Workforce Policy Advisor to Governor Whitmer. Brandy, thank you very much for being with us today. And we also have Dr. Natasha Bagdasarian, Senior Public Health Physician with the Department of Health and Human Services. Dr. Bagdasarian, thank you very much. And for our members that are on, I want to, thanking both of our folks today for being with us, but I also want to really extend a thank you to the governor's office and to Brandy. Throughout the pandemic, while we may not always as an organization in the governor's office agree on everything, they have kept us in the loop. They have consulted us on issues that are relevant to us. They've worked particularly with Jen and with Brad on legal items, and even leading into last week particularly with the antigen testing and the joint kind of effort to get schools to think about physical reopening by March 1. We had multiple meetings that Brandy was in and Dr. Bagdasarian were in and myself looking at, how can we do this appropriately? And the governor was reaching out to the education groups to do that. So I do thank you for that working relationship, Brandy, and thanks to the governor for putting you in the space to be able to do that. For today, for all those that are in attendance, we are going to really turn this into a Q&A session. I think as we've seen with when the governor was on with us in the fall, when we had Dr. Rice with us, there's a lot of questions from our members on these topics. We will only be using the chat function at this point, so everybody will remain muted during this just to facilitate things. Both Jen Smith and I will be monitoring the chat and posing questions to Dr. Bagdasarian and Brandy. They can decide who is best able to answer them. Stacy Bogard, as always, is kind of managing access and is going to manage the muting. But at this point, I am not anticipating having people ask verbally. So I ask you to start being able to use the chat function to type any questions that you might have. I'm going to start this off with just a couple of questions. And as we go forward, please feel free to throw out questions. I know we'll have a number of superintendents on today also as they're looking to implement, and board members also wondering how things are going with both antigen testing, vaccination, and reopening, as those are all questions. So if we're ready, we're going to get started. Brandy, ready to go? Dr. Bagdasarian, ready?
Yeah, so, well, thank you so much, Don and MASB members. I'm truly grateful for your partnership during this pandemic. I think one silver lining of this pandemic is that it has brought, at least I'll speak for myself, it has brought me so much closer to the education associations and those of you on the ground doing the work. Because of the necessity of the emergency that we are in, it has, really called for constant communication. And I think it's really strengthened relationships and partnerships that I hope will continue post the pandemic. I know sometimes I'll call Jen at like 9 o'clock at night and she always answers and is always appreciative for the dialogue. So I do want to express my sincere gratitude. So just to give some opening remarks, and then I'm going to hand it over to Dr. B. last week was a big week for some education-related announcements from the governor's office and our Department of Health and Human Services. Last Wednesday, we announced that we were going to move forward with a partial 1B vaccination distribution, which meant those who are employed by schools and really working with students in person on a day-to-day basis would begin to be eligible for the vaccine starting Monday, which was yesterday. And so that is really exciting. We know that county local health departments are a bit, all over their map with their ability and capacity to get moving. Some are starting to educate teachers as early as next week, and others will take a couple more weeks. We hope to, we are pushing out the vaccines as soon as we get them, and just know that teachers and educators are a real top priority in terms of vaccination. So that announcement sort of then teed up our announcement on Friday. And so just to recap what we announced on Friday at the press conference, the governor announced that she was establishing a goal that all school districts offer an in-person learning opportunity to all students no later than March 1st, and certainly earlier if possible. She spoke at length about the value of in-person learning and the importance of facilitating in-person learning. She and Dr. Khaldun both talked about what we have learned from data and research about the relative low risk of transmission in schools when schools implement infection prevention protocols, and that those schools that have been open for the most part this school year have done an incredibly good job about adopting and implementing those mitigation strategies with fidelity. So we wanted to also acknowledge that. She also talked about and sort of previewed what we are going to talk about today, that we were going to make rapid testing available to schools as yet another tool to help make schools safe for students and educators. As many of you know, we worked with the Michigan High School Athletic Association over the past several weeks to really test this concept. Although we are, pleased that we were able to help these high school athletes finish their postseason, I'll tell you that our true motivation for partnering with MHSAA was that we really wanted some willing and enthusiastic guinea pigs to really prove the concept of whether or not we could deploy these rapid antigen testing in K-12 school environments, certainly for staff, but also potentially for students. I think Dr. B will share a little bit more about that pilot, but the bottom line is that it went pretty well, and that the positivity rate among athletes and coaches was low. The compliance with reporting the necessary data was high, and they were able to catch positive cases of asymptomatic athletes and coaches before they began their practices and games, thereby preventing outbreaks. And so based on all those lessons learned, we are now beginning to roll out a voluntary program to offer testing supplies in schools and educators across the state. And so again, the governor just really encouraged school districts to provide as much face-to-face learning as possible. She reminded us to pay particular attention to young students, economically disadvantaged students, students with special education needs, and English language learners. And then released updated guidance that Dr. Bagdasarian took a leadership role in developing, along with a document that we call the rationale document, which kind of outlined our key learnings about both the importance of in-person learning and the relatively low risk that school environments provide, and sort of linked the document to the various academic studies and research that we consulted when making this really important decision. The guidance that we produced is really important. It serves as an update or a refresh of the return to school roadmap. We released that on June 30th, 2020. And in the last 6 months, we've learned that much more about how to prevent infection. For example, the roadmap, went into great detail about disinfecting surfaces. And we spent a lot of time trying to get Clorox wipes to schools. And of course that's important, but we now know that mask wearing is so much more important. In the original return to school roadmap, we said that students wearing masks in pre-K through grade 5 was optional. And now we look back and think that was really silly, that of course masks need to be required in school environments. And so the guidance reflects that updated knowledge that we have about the ability to control infection. It also replaces the document that was actually never formally published by MDHHS, but was shared with local health departments and thereby shared with many school districts. We called it the matrix, but it was that document that provided recommendations on when to be open or closed or hybrid based on case rates and positivity rates. The guidance we provided really does replace that. In essence, we learned that even when case rates are extremely or relatively high, or positivity rate is relatively high, we can still provide in-person learning opportunities to schools when we do implement those careful infection protocols. Sorry, that was my son. So again, just wanted to say thank you to your leadership. I know the job this year during the pandemic has not been hard for our locally elected school board members. It's incredibly difficult. I know that you all are under a tremendous amount of pressure. So with that, I'll mute myself so that my son Kirby doesn't continue to interrupt this webinar, and I'll turn it over to Dr. Bagdasarian. Thank you.
Thanks so much, Brandy. I think that was a lot of information, and I would like to give you a little bit more information about what this entails, and then we can open it up to questions if that sounds okay. And I do have just a few very brief slides, if I can just share those. I will introduce myself as well for those of you who don't know me. My name is Dr. Natasha Bagdasarian. I'm an infectious disease physician by training, and for the last 6 months or so, I've been working with the Michigan Department of Health and Human Services in testing strategy. And we, just to give you a little bit of the background, we received a large number of these very, very helpful tests called Binax antigen tests from the federal government. And we have used them since the fall in various high-risk populations. So we've used them in nursing homes, we've used them in prisons, jails, all kinds of different places, adult foster care. So we have a lot of experience now using these tests. And we also have overcome some of the logistical issues that some have encountered. And what these tests have shown us is that they can be run by pretty much anyone and pretty much anywhere. They're extremely rapid. You can get the results back in 15 minutes. And while they're not as sensitive as the lab tests that are sent to hospital laboratories, for example, those are PCR, they're not as sensitive as those, but they are able to tell us if someone is high risk, if they're shedding large amounts of virus. And as Brandy mentioned, we recently tried them out in 200 schools to see if the same model that we've been using all over the state, if it's feasible in schools, because our goal is to protect students, protect teachers, and get people back in school in a very safe way. And it was an overwhelming success. So I'll share with you just a little bit about specifically what I'm talking about with antigen testing. So this is just a little excerpt from the new guidance that we put out. And I hope that the guidance is helpful to you all. What we try to do is take this massive document that had tons and tons of detail and distill it into the most important points. We have a lot more experience now than we had over the summer. We know how schools were able to stay open and what was safe and what was less safe. And so the guidance really distills the most important ways to keep schools safe and open. And then in the guidance, we did add a little bit on testing. I don't think that testing is the be all end all. It's an extra tool in the toolkit. It's something to keep in our back pockets for our frontline educators to feel safe and protected and know that we're doing something extra for them. So that's really the way that I look at this. And I just want to highlight a couple things. This testing is not a requirement for schools to return to in-person learning. Schools that are following existing guidance are not considered major risks for outbreaks. So overall, we found that schools do reflect what's happening in the community. If there's a lot of community spread, chances of having some transmission in schools is also higher, but schools have proven themselves to be much, much safer than other locations. For example, indoor dining and restaurants, for example, schools are places where people follow the rules. And because of that, we don't see high levels of transmission. And again, testing is just an additional tool that might help educators and students return to the classroom in a really safe and measured way. So this is sort of what I'm talking about with a big picture. I'll tell you just quickly what happened with our school sports testing pilot, just so you know what we've already done in terms of laying the groundwork. So already we have, we've rolled out this type of testing in thousands of facilities across the state. But for schools, we enrolled 200 schools who wanted to finish their fall season. They were highly motivated. They said, tell us what you need us to do and we will do everything. And so we wanted to see if it was feasible. Did it work? And it allowed 7,000 student athletes and staff in 200 schools to participate safely in playoffs. More than 99% of the tests were negative. And testing these student athletes and staff allowed us to uncover 43 COVID positive cases and quickly isolate them. So we did not have big exposures. We didn't have large outbreaks as a result of this. This is what the test looks like. So the technology is actually very similar to a home pregnancy test. It's looking for a protein, just like home pregnancy tests. The only difference is it's not a urine sample, it's a swab up the nose. But it's not the swab that goes all the way up here. The brain tickler is sometimes called. It's not a brain tickler. It's just a nasal swab just down here. And people can collect it themselves. So if you feel comfortable sticking a Q-tip up your nose, you can self-collect the swab. And it's just a little Q-tip. This is what the card looks like. So it looks like a old-fashioned, not so high-tech pregnancy test. And you're essentially looking for one line versus two lines. So pretty simple. There is a little bit of reporting that has to be done. So the results have to go into an online portal. And for some schools that participated, that was the most time consuming part of it. The test itself was pretty quick and easy. And actually, I'll rewind here a little bit. So in our sports testing pilot, we heard that some teams were able to test 80 people an hour with 4 staff working on this. So it goes by quickly. And what we would be talking about for a widespread school testing initiative is only doing this on a voluntary basis. So it would only be school districts that were interested in participating, and individuals would have to consent to participating. And we really want to make sure that there was good stakeholder engagement, that people knew that this was something going on at the school, that there was some engagement with educators, school nurses, parents, letting them know that this is something we're planning. The testing that we can offer currently statewide, because it's a finite number of tests and there are a lot of schools in Michigan, would be weekly testing of educators. So that's what we're talking about as a baseline. And then if some school districts wanted additional testing, maybe testing of students, that's something we might be able to work out in terms of a pilot. And that's really all I have. I think we can take some questions now. We will have a webinar on Thursday where we talk about the nuts and bolts to a broader audience. But I will go ahead and see if Brandy has any comments, and if not, maybe we can take some questions.
While you were talking, I've been kind of taking some of the questions in the chat. I'll turn it over to MASB. I know they're to maybe facilitate some of the questions that I haven't got to yet, but I'll just keep on plugging away at some of the specific questions. I know there's a question about school board members being eligible for the vaccine. At this time, they are not, unless they fall into one of the other categories that are eligible, like if the school board member is a healthcare worker or a first responder or 65 and older. I hear your feedback loud and clear. I will commit to providing that feedback back to MDHHS as they further refine their priority populations for future rollout of the distribution of the vaccine. A couple of questions that came up that I'm not, just to be very crystal clear, that the state would provide these rapid tests for free to schools. There's not an expectation that schools would purchase these tests from the state. We would make them available, including shipping them locally, and also do the training for the individuals that would be interested, or the individuals that would be responsible for administering the test. So just wanted to be clear about that point as well. So I'll turn it over to MASB.
All right, thank you very much, Brandy. Thank you, Dr. Bagdasarian, for laying everything out. We do have a lot of questions. I will say, I will try to get through every question. When we get to the end, we may not have that. We will share the questions with Brandy, but I also know she's doing a webinar with MASA tomorrow. They have a larger one that was just mentioned on Thursday. Time may just not allow for them to get back and answer these questions. I think you guys are actually working on an FAQ too in this space. So MASB will do our best in this space to get questions that don't get answered. We will put stuff up on our website already. We have the new guidance up on our website, so you can go there and get that and see that information. But just understand that. So I saw the ones that you answered, Brandy. I'm gonna start rolling through these. You mentioned the antigen testing, doing it weekly, for our teachers. One of the questions posed is, districts are using substitute teachers, substitute bus drivers. You can't, I guess, calculate that into the number, but I would anticipate that if I've got a sub in a classroom this week and they've agreed to testing, we can do antigen testing on them, and it's not going to skew the availability of tests in that space.
No, I don't think that would skew the availability of tests. We're dealing with such large numbers here. I think it would just make sense to test whomever is engaged in face-to-face teaching that week when testing occurs.
And, all right. And we also recognize that for those added individuals, there will likely be individuals who wish to opt out. And so, our calculations were largely based on, educator counts. But when you take away those that opt out, it provides more availability for those others that want to opt in.
Here's a question actually on vaccination, not on antigen testing. As we think about phase 1B, and I know the governor's office has talked about those educators that have direct contact with students. So if we have substitute teachers that are regularly within our districts, would they fall into our 1B, or would we sign them up for our 1B testing? And I'll give you the example, districts often will have a sub list throughout the year. And we have districts that have they've used that whole sub list as in that these subs are in their districts probably once a week, if not more. And would you expect that even though they're not full-time educators, if they're in contact with teachers, that they may be eligible for the 1B access to vaccination?
Brandy, do you want to take this or do you want me to?
Go for it.
So one of the things we're really trying to do is get as many shots in arms as possible. And so if someone is deemed a teacher and they are engaged in some face-to-face teaching, I don't think anyone at a local health department or a vaccination clinic will quibble based on that. Our goal is really not to make these hairline distinctions, but to get as many shots in arms as possible into those who are in these risk groups.
Okay, and I know I've talked to at least one district that they were asked by their health department to give a list of names that would be, eligible as educators. And in that case, they could add that substitute teacher or teachers on the list and go forward until, as they're available.
I think that if there is a local health department who's specifically asking for a list, it would be fair to give them, the details of who is a substitute and who is full-time, if they're making those sorts of distinctions. But for a lot of vaccine clinics, I know that they're not doing lists and they're not doing vetting, and we're really trying not to quibble a whole lot. So, whether you're teaching, a few times a month or teaching every day, if you're an educator, I think it just makes sense to get people vaccinated as fast as we can.
All right. And I know Brandy answered this question within the chat. We've had the question, Jen's had it, Brad's had it, about board members specifically. And ultimately, if they meet the other qualifications as a first responder, healthcare worker over 65, a board member qualifies. But because board members don't typically, and particularly in where we're at right now, don't have direct contact with students, we want to make sure that our teachers and other educators are getting those vaccinations before board members are eligible for that. Question, this is from Jason Shane. When talking about schools not being a major risk, do you mean full-time or hybrid? What was the population density, class size? So I know EPIC did one of the studies out of MSU, Brandy, looking at Washington and Michigan. Is there differentiation in that study about, and I know the guidance talks about still keeping X feet, 6 feet apart and other things, but do you have an answer that's more detailed?
Yes. So the guidance represents kind of the gold standard best practice about what we know on how to mitigate the spread of COVID-19. Obviously, first and foremost, masks need to be universal, period. That is our best mitigation strategy. In terms of spacing, we provide guidance, and spacing does matter. So the recommendation, although this is not a mandate, the recommendation from our experts at MDHHS is that desks are spaced 6 feet apart. If desks cannot be seated 6 feet apart, school districts should consider a way to de-densify the classrooms, either by using a larger space and getting creative about using things like cafeterias or auditoriums or larger areas where you could spread the students out more, or de-densifying by moving to a hybrid model where groups of students are in sort of smaller pods and meeting together, sometime in the classroom and sometime, not at school. So that is the best practice. Again, it's not a mandate. If a school was to decide that, full participation of students 5 days a week is incredibly important and 6 feet is not achievable, DHHS strongly recommends at least 3 feet of distance between students, and then to also consider additional mitigation measures like installing, barriers but between desks. Dr. Bagdasarian, is there anything else you want to add on that?
Nope, I think that's correct, Brandy.
Yeah, I'll just say one more thing as just a reminder that I think all of you know. When we developed the roadmap over the summer and it was published in June 30th, that same day we issued an executive order that really institutionalized via the executive order those protocols that were the minimum requirements to open up schools. In October, when the Supreme Court ruled that the law that the governor was utilizing to issue executive orders was unconstitutional, the ability to make these things mandates became more difficult. We are operating under the authority of Director Gordon and his epidemic orders, and that largely allows him to sign epidemic orders related to limiting gatherings. And so while we continue to use the epidemic orders for that purpose, as well as the MIOSHA emergency rules, just a reminder that the guidance that we issued on Friday is just that. It's guidance and really represents the best practices that we know from epidemiologists and others with expertise in infection control.
Thanks, Brandy. And for those that have not been open, that are in densely populated areas, if we look at others that did open this fall, what we also saw was that even though the option was there, we would have upwards 40-50% of parents not choosing to return. That still may happen in the spring during this process. And so even if a school is reopening and hoping to try to have, give access to all by March 1st, you might very well, if you have not been open, and I live in Grand Ledge, we haven't been open, it might be a situation where still you'll only have, 60% participating, thus making it easier to get into the spacing and some of those guidelines. So it's the right question to ask, but also there, as we move forward, you might survey, figure out how many people are coming, and decide what makes sense. I see another question. If staff has received the COVID vaccine, would you still include them in antigen testing? Probably Dr. Bagdasarian.
Yep. I think that it would be perfectly reasonable for staff to opt out if they've received the vaccine, but it's going to take us a little bit of time to get there. So, things are just ramping up with vaccination of this group. We have to wait for people to get the first vaccine, and then it could be up to 28 days to get the second vaccine. And then it takes some time for the vaccine to be fully effective. So we're talking a couple of months here, probably for the very earliest teachers who get immunized. So what I'm recommending is that we proceed with this testing cadence for anyone who's interested. And then once we feel like we have reached good levels of teacher vaccination in certain areas, we can discuss scaling back. But if you personally are enrolled in the program and you've been vaccinated and it's been a month since your second vaccination, it would be perfectly reasonable to opt out.
Thank you. Looking at the new guidance for either of you, any changes that affect special needs programs or special needs students in that space, or has that remained pretty constant with this new guidance that came out last week?
I think it remains. I think it remains pretty constant, although it does remain constant. But I will say, in conversations I've had with some districts across the state, it was, I had some great conversations with some superintendents about why this testing protocol would be that much more important or useful for those that are working with special needs students, where distancing is quite impossible, that by the nature of the services that are being offered, distancing is functionally impossible to achieve. They may be the first ones that would want to sign up to do this antigen testing as another layer of safety.
Okay, thanks, Brandy. Another question that came in, this is on a kind of process or communication process. How is the state contacting the districts to, directly, so that the superintendent knows, here's how I get the antigen tests, and here's the email or the phone number I need to call to have X number delivered to my district?
Yep. So we're working on that right now with MDHHS. As Dawn mentioned, we are doing a similar webinar as this with superintendents tomorrow. We're doing one that's just broadly available to anyone in the education space on Thursday. We're doing one with high school principals on Friday. So we're trying to kind of get the word out and hopefully build some interest in this program. The materials to sort of sign up are going to be available on a website, which is michigan.gov/school COVID testing. Right now, that has some documents that are that we have created for the MHSAA pilot. So they're not completely applicable, but they are pretty applicable in terms of describing the program. That's also where the guidance that we've been describing, as well as the rationale document I mentioned, are posted. I'll put the link in the chat, but we are working right now to develop like a form that districts would complete to opt in to this program, and then to indicate which buildings or which educators will be participating. So that is a work in progress, but we hope to have that available by next week.
All right. You've answered the question a little bit in the chat about you've encouraged local health departments to follow the new guidance. Many health departments had created kind of an alphabet, or color-coded risk factor sort of space. What do you expect? Like if we were to see, we're March 1st and we're all moving in this direction and we see a surge in cases, is there a space there where, whether it be with the local health department or at the state level, that we might still have a situation where schools on their own or in concert with their health department or the state, that you might say, this might be a good week to go to a hybrid or move back to completely online? Or are we really saying schools can do this regardless of what the community numbers look like?
Yeah, that's a really great question. So let me take a stab at it, Dr. Bagdasarian, and then you please jump in and add. So what we are, and I do recognize, I also live in a school district, and actually Dr. Bagdasarian does too, that where the public schools have been closed or operating remotely for this entire school year. And so I understand how frustrating it is. I attended my virtually attended my school board meeting yesterday as this was being debated and discussed. And I do recognize the frustration of kind of making a decision to utilize the hard and fast numbers and metrics that were decided upon earlier, and wanting to stick with those. But our message is that we've learned so much more about this virus that those numbers around case rates and positivity rates and the triggers or the thresholds that we created along those lines are just not good indicators of when schools should be open or closed. We know now, and we have much better data from the EPIC study that was mentioned, other states that have largely been open, and then other countries that have largely been open, that even when those rates are relatively high, schools can still be open with very low risk when the infection mitigation measures are followed. So to answer Don's specific question, yes, there could absolutely be scenarios where the state issues an epidemic order that says schools need to suspend operations temporarily because of a huge spike, and the same thing at the local level. However, there would be contextual factors beyond just a hard and fast threshold that we would take into consideration. So for example, when Director Gordon signed an epidemic order in mid-November that that suspended operations at high schools temporarily. Obviously, we were seeing a huge spike in numbers, but one of the things that was fundamentally broken across our state was contact tracing. Local health departments were unbelievably overwhelmed with contact tracing responsibilities, and needed the state to kind of quickly stop or pause, as we say, in order to get that better under control. Once we had that public health capacity better, the capacity was increased, we very quickly said that high schools were allowed to reopen. So it wasn't just because there was a magical number, it was because the public health capacity was strained. The same could be true at your local or regional hospital with ICU bed capacity. That is absolutely a factor that should be taken into consideration when making opening and closing decisions. So that, for all the reasons I just said, that's the reason why we have moved away from using the phase system and the matrix, because those indicators taken in a vacuum don't really provide the full contextualized tools that we need in order to make those decisions.
And I think ultimately in our conversations over the last few weeks, I mean, in the end, this is not a mandate, as Brandy is, this is local districts still making the decision how best this will work for them, even though all of us, and I don't think there's anybody on this call that doesn't think that getting kids back to face-to-face learning is what we all want. So, I mean, I think communities have to do what is right within their community, but this is providing extra data information to know that many districts across the state and across the country have been able to do this, and schools have done a phenomenal job of following the guidelines that have been out there and have kept kids and our employees safe because of that. How quickly, can schools right now reach out and start getting the antigen testing? Or I know that you mentioned the website, Brandy. I don't know if that's up and running. I know the 200 test schools have had them. How quickly can they start applying to get those antigen tests?
Dr. B, you may have a more precise answer, but our hope is that by next week, we would enable the sort of request form that I described. Does that sound right, Dr. Bagdasarian? Okay.
I see a question, and Jeff, you might have to restate it. It says it was mentioned that it's available for face-to-face for the first round. Can you verify this? I'm not sure what that question, so if he reposes that, that might help us know what the answer is on that.
If it's a vaccine question, I imagine it might be a vaccine question. If it is, then right, the vaccines are in limited supplies in our communities, and so those educators that should be prioritized are those that are going to be working face-to-face. If an educator is planning to be remote for the remainder of the year, or if there's no imminent plans to return to school, I think, our guidance is that we should reserve those vaccines for those on the front lines.
Question out of Oakland, Wayne, and Macomb. Of course, their population density is higher. When you look at the data that's helping guide these decisions about reopening and saying that it's safe, are those population densities factored into that research to say that whether you're in the UP doing it or whether you're in Wayne County doing it, that schools have been able to maintain that safe factor?
Yep. So like I said, we've looked at studies from the one we mentioned done by EPIC was very geographically representative of the different regions of our state. They also looked at school districts in Washington state to give another state's context that also has areas that are more densely and less densely populated. But we looked at research and studies from other states in the country as well as internationally. In Europe, schools have largely been open throughout the pandemic. And so we've been able to actually glean some really good research from their practices. I can certainly put a link to the EPIC study in the chat. They've been incredibly responsive and a really great research partner. And so if you wanted to dig in with the primary researcher on that project, Catherine Strunk, I know she would be really happy to hear from you. So I will add her contact information in the chat as well.
Thanks, Brandy. This is a broader vaccination question. And I know the governor has been pushing at the federal level to get access. Yesterday, she asked to have allowance for the state to purchase directly. The question is, when do we anticipate, having enough vaccinations to be able to vaccinate all interested and eligible staff? What is the vaccination, as the feds have been talking about how many are coming into the state? Like, how quickly do you think we'll have enough so that in this kind of phase 1B educator space and over 65 that we'll be able to get most of them? Are we talking a month from now, 2 months from now? What are you thinking?
Would you like me to take that, Brandy? Sorry. It's very difficult to predict at this point because we're not doing these phases one after another. There's overlap. So it's difficult to specifically talk about how many vaccines are available for teachers when we're also vaccinating police officers and emergency medical technicians, and there are still healthcare workers left over from phase 1A who are being vaccinated now. So it's tricky. And I think all I can really say is that we're working on this and we want to get shots in arms as soon as we can. How the rollout goes over the next couple of months is yet to be seen. I am hoping that we reach a place where the majority of our teachers are vaccinated in the upcoming months, but I'm sorry, I don't have more, I don't have a better answer for you.
Thank you. As we think about reopening and face-to-face, Brandy, questions that have popped up is in the special needs place. Clearly, for some of our students in special needs programs, mask wearing is not a feasible alternative. And schools have been grappling with that all year. But if they're not able to wear masks, and maybe at this point, and maybe even a month from now, that staff member hasn't been able to get vaccination either, I'm gathering from what you've said in the past through this conversation even, that at that point a school make a decision to say maybe that's not the best approach to go back face-to-face in that environment, but it would be on a case-by-case basis rather than you're going to expect at the governor's office that every kid's going, whether they can wear a mask or not, and whether their teachers are vaccinated or not.
Yep, ultimately, again, we can't emphasize this enough that those types of decisions are made at the local level, and of course the governor's office will respect them. We hope our announcements really set a North Star goal. We hope that it is encouraging and provides additional resources for school boards to move and school administrators to move towards opening for face-to-face instruction, but ultimately those decisions will need to be made at the local level. For what it's worth, I don't think given the announcement we made on Wednesday, for educators, given their high priority, I don't think it will be months and months of waiting. I do anticipate that educators will largely, at least be able to get their first dose within the next, month and a half. I have the pleasure in sitting, we call them C4 tables, but we do these regional community roundtables every week with various regions across the state. And so I have the pleasure of hearing from local health departments in every corner of the state about what their plans are, and most feel confident that they will be able to get to educators quickly. As we think about other populations in 1C and certainly in phase 2, I think that's a much longer time frame. But as Dr. Bagdasarian, we are literally going as fast as we can, and are somewhat dependent on the federal government to get access to the doses we need.
Okay. Somewhat similar to an earlier question, but a little different bent to it. if someone's been vaccinated and upon antigen testing or other testing, they've been in close contact with a positive test, do those individuals also still need to be quarantined like we've done in the past, or because they've been vaccinated, they could stay teaching if it was a teacher, for example?
Dr. Bagdasarian, do you want to take that one?
Sorry, could you just repeat the question for me?
Sure. If we have somebody that's a teaching staff member that's been vaccinated and they find out, that they've then had close contact with a positive test, do they still need to go through the quarantine process and we would remove them from the school, or because they've been vaccinated, we can leave them in the classroom?
So for right now, CDC guidance has not changed. For right now, if someone has been exposed, we would still count them as a close contact. However, I anticipate there being new guidance at some point soon. We do have to remember that vaccination, although highly effective, these vaccines are approaching 95% effectiveness. No vaccine is 100% efficacious, but I anticipate there will be new guidance on that from the CDC.
All right. With antigen testing, if the school district gets a positive result, of course, there's all kinds of privacy guidelines that enter into that space. Are we still expecting in the contact tracing space and reporting space that information is provided to our local county health departments, that we're not in a situation where schools are having to report to the state? We're still reporting locally, and we have to, I would imagine, keep that information as far as the individual. That all has to remain just like we did in the fall. Even if it's our own antigen testing happening, none of the privacy pieces change or anything along those lines.
There is a secure online reporting tool. So all of the information gets put into the online reporting tool, and then information goes directly to state and local health departments.
Okay. And the reporting tool is HIPAA compliant, has been through sort of rigorous legal review in terms of compliance with privacy laws. The rules around privacy are a bit different when we're talking about public health surveillance, which is what we're talking about here. But I think that I know some school legal firms are working on some guidance or maybe some FAQ. For example, we wouldn't recommend that the school create and then retain records of the test results at the school. Someone that is working on administering the test will be responsible for inputting the data into this secure and safe portal. But from that point, there should be no records. So that's an example of a way to comply with the HIPAA issues.
Okay, I'm going through a couple. I know we're coming up on our time here. In person, we have already answered this one. People that are in-person instructors right now should be receiving their vaccinations before those that are in the virtual instruction space. Do they need to register for the webinar on Thursday, or can they just click on that link when it happens? Okay.
Yeah, it's a Teams live event. And so for that, it's almost like sort of like a live stream type situation.
Okay. That question was up. That one's been answered. Regarding opening schools, we have an issue with securing sub-teachers when our teachers are quarantined. We have lists that we work from, but this still remains challenging. This is a conversation. I don't think there's an answer, Brandy. We've talked about this. I know you and Jen have talked about it. We've been meeting with the Department of Education. I mean, clearly there is just a shortage of available substitute teachers. Maybe with the increase in ability to vaccinate, some of those folks that are eligible to be subs that have held back this year, if they can get the vaccine, might be more willing to, in fact, get back into that. But that is an issue that's out there. May I ask that we consider rural areas and access to vaccines? Local health department says we're at least 4 weeks away from vaccines for staff in rural areas, while in some other areas that are more populated, they're already getting their first dose. So I think this question just is, as you distribute based on and I think it's based on population, but for school districts, you may have a small population density in a rural county, but if we're trying to get enough doses into those rural health departments, it might not match their normal distribution amount just because of how many teachers or school employees, I should say, that we're looking at there. So that's not a question, but just more of a request to think about as you're looking at that distribution. Is the training for administering the test going to be as the tests are received or open to any district as they're anticipating getting those antigen tests?
I imagine we'll facilitate the training for any district that does, take the step of like ordering the tests and has agreed to the pilot. We have a really phenomenal woman who does the training that has had a lot of accolades from our athletic coaches because she did such a great job with training. She makes it kind of fun and really easy to understand for a layperson. As Dr. Bagdasarian said, it really is kind of like administering a pregnancy test. And so it's relatively, a layperson can do it. It's not something that someone with a medical background needs to necessarily be the one administering the tests. And so, yeah, once a school is sort of committed to doing it, that's when we'll train.
All right, we're at 101 right now. I want to recognize Brandy and Dr. Bagdasarian's time. One, I'm just going to make a comment that's listed here. Brandy, I know you and Jen have talked about this, but it was a question that was, will school boards be able to get back to meeting in person on the 15th? I know that that's something you guys are talking about, and unless you are able to share some great announcement right now, I don't think you have the answer, but we have been talking to Brandy regularly about, as we try to encourage schools to reopen, that boards also may have that same function again.
Yeah. So, I can't share, but I will say, I do anticipate that, within the next 24 hours or so, the epidemic order that is about to expire, will be, amended and then reissued. So I think we're really looking at likely tomorrow, which shouldn't be any surprise, generally speaking, about 2 to 4 days before order expires is when we tend to update them. So I would just stay tuned for announcements tomorrow.
And my last question, as we look at kind of state capacity, so applications likely look like they'll be able to start next week for the antigen test. And it sounds like the capacity from state perspective will be that you'll be able to start distributing them almost as quickly as you receive the applications.
We really, our first goal is to make sure that people know all that is required. So there are a lot of pieces to get in place. It's not a question of how quickly can we get the test to you. We've got a warehouse full of tests. That is not the limiting factor. We want to make sure that people are trained, that they feel comfortable, that they don't have any barriers, that they know what kind of PPE they need to use when they're doing these tests. We want to make sure they know how to dispose of the test. So those are really the rate limiting factors, not so much how quickly can we get the test to you.
All right. Thank you very much. There are other questions. I think we really, as I went through them, I got to the end of the meeting other than a couple. So I think we did a pretty good job of answering all that were posed. Thank you both for being on with us today. It's really helpful for all of our members. We were able to reach out and touch a lot of school districts today, SUPS and board members. To the both of you, thank you very much for you working with MASB on this. And to the members that attended today, thank you very much for taking advantage of this opportunity. And thank you for what you're doing in your districts. To the superintendents and board members, it's been a rough year, and you guys have done an amazing job in keeping our kids educated. So thank you to everybody. And with that, I will let everybody go and to have a good afternoon and good remainder of the week.